off a woman's life. Others will perform the procedure under no circumstances at all. At the same time, many states have passed legislation to shut down the freestanding clinics that are now responsible for most abortions by enacting cumbersome and expensive building regulations that are disguised as patient safety requirements. There are now 25 states that, under patient safety, restrict abortions to hospitals, which is specialized facilities. In our view, hospitals have disregarded the responsibility that our academic predecessors expected them to assume. Although most first trimester and many second trimester abortions can be done safely and efficiently in a clinic setting, some second trimester abortions, particularly those that are complicated by medical conditions, should be done in a hospital with rapid access to the operating room, interventional radiology, blood bank, and other emergency interventions. Hospitals and expert clinicians are essential for the education of students and training residents who care for complicated cases and for treating complications. The 100 professors went on to say that physicians should learn uterine aspiration, which is an outpatient procedure that today accounts for 82.3% of abortions, and local anesthesia and analgesia, which includes conscious sedation, so that complications and expensive general anesthesia would be reduced. Today, some hospitals confine pregnancy termination, even routine first and uncomplicated second trimester spontaneous and induced abortions, to operating rooms and have credentialing rules that prohibit the use of conscious sedation for these patients. Ignoring the 100 Professors Council not only dramatically increases patients' recovery time and expense, but also adds significant and unnecessary staffing and clinical costs that discourage hospitals from providing abortions at all. Regarding hospital practices and the role of abortion committees, the 100 professors therapeutic abortion boards will have no place, and states with laws which stipulate that abortion decisions are to be made by the physician and his or her patient. The 100 professors commented on the physician's duty to counsel regarding abortion. There are patients who should be actively encouraged to consider abortion. For example, women who are unaware of the teratogenic threat to their pregnancies. At the same time, the professors would have been thinking of rubella and did not know that advances in prenatal diagnosis would give obstetricians the opportunity and responsibility to make their patients aware of a wide range of genetic anomalies and to offer abortion if requested. The 100 professors certainly would not have envisioned the legislation recently proposed in Oklahoma to entitle physicians to withhold information in cases of known fetal deformity because a knowledgeable patient might choose termination. Writing about doctors with conscientious objections, the 100 professors said that these physicians must be excused from performing abortion, but must refer patients to colleagues who can care for them. Recent conscious clause legislation does not require referral for abortion. In some states, specifically prohibit referral for abortion by physicians who work in institutions that receive state funding for women's health services. The American College of Obstetricians and Gynecologists, which discusses the limits of objection, recommends that any conscientious refusal that conflicts with a patient's well-being should be accommodated only if the primary duty to the patient can be fulfilled. Despite this guidance, many physicians are now prohibited by law from referring patients to vital services. Abortion is certainly service in this category. Freestanding clinics provide faster. Some hospitals with abortion services still, even though residency programs have integrated abortion training successfully, individual states and recently the U.S. Congress have legislated restrictions on abortion training in disregard of Accreditation Council on Graduate Medical Education training mandates. These restrictions ultimately threaten women's health by denying residents training in uterine evacuation, which further reduces access to safe abortion. The 100 professors considered the consent process for abortion, stating that it has been ruled by some courts that an adult woman is free to make this decision herself. However, several state legislators have interfered in the consent process by requiring that irrelevant, even untrue, information be given by the physician. For example, abortion causes breast cancer and fetal pain, and enacting burdensome waiting periods that increase risks and costs. They further predicted that the courts will someday decide that any girl who is physically mature enough to conceive should ipso facto be granted the freedom to determine the fate of her pregnancies. Yet politicians in 37 states have restricted freedom of access of minors to abortion by implementing parental consent and notification laws, often with clumsy, prolonged judicial bypass requirements that lead to dangerous delays. The professors addressed the need for post-abortion contraception to decrease the need for abortion, endorsing it as an integral part of any abortion program. But today, the most effective contraception responsibilities to, one, teach future practitioners about all methods of contraception and about uterine evacuation throughout pregnancy, which ranges from miscarriage management to emergent evacuations and the treatment of complications in accordance with mandate from the Accreditation Council for Graduate Medical Education. 2. Provide evidence-based information to all patients who seek family planning or pregnancy termination. 3. Provide evidence-based information to legislators who propose laws requiring inaccurate information or unindicted procedures for women seeking to terminate a pregnancy. 4. Insist that hospitals where we care for women and teach students and residents admit patients who require hospital-based pregnancy terminations. And 5. Ensure the availability of all methods of contraception, particularly long-acting reversible contraceptive methods, to reduce the need for abortion. I am now reading from Legislative Interference with the Patient-Physician Relationship by Stephen E. Weinberger. Increasingly in recent years, legislators in the United States have been overstepping the proper limits of their role in the health care of Americans to dictate the nature and content of patients' interactions with their physicians. Some recent laws and proposed legislation inappropriately infringe on clinical practice and patient-physician relationships, crossing traditional boundaries and intruding into the realm of medical professionalism. We, the executive staff leadership of 5 professional societies that represent the majority of U.S. physicians providing clinical care, the American Academy of Family Physicians, the American Academy of Pediatrics, the American College of Obstetricians and Gynecologists, the American College of Physicians, and the American College of Surgeons find this trend alarming and believe that legislators should abide by principles that put patients' best interests first. Critical to achieving this goal is respect for the importance of scientific evidence, patient anatomy, and patient-physician relationship. Examples of inappropriate legislative interference with this relationship are proliferating, as lawmakers increasingly intrude into the realm of medical practice, often to satisfy political agendas without regard to established evidence-based guidelines for care. Of particular concern are four specific types of laws or legislative proposals. The first type of law prohibits physicians from discussing with or asking their patients about risk factors that may affect their health or the health of their families, as recommended by the evidence-based guidelines of submission of an appeal of Judge Cook's ruling. Second, some new laws require physicians to discuss specific practices that